Hi, everyone. Thank you for joining us tonight in this conversation and this panel. My name is Daniela Gonzalez Rios, and I'll be serving as your moderator this afternoon. So we'd also like to take an opportunity to see who else is in the room. So if you can go ahead and introduce yourself in the Zoom chat by sharing your name, your organization, or your role. And if you're joining as a parent, caregiver, or youth, we invite you to share that as well. So while you all do that, I want to go ahead and share some of the community agreements that we have today to help create a more welcoming and productive space so that we can all be in agreement. Just listening to understand. Give me a second, let me pull up the we want to make sure that we are actively listening and that we continue to honor the lived experience of the people that are joining us today as expertise, that you continue to speak from your own experience, and that we're also being mindful of time so everyone has an opportunity to participate. So if you haven't spoken or have a question, we ask you to lean in, and that if you already have spoken or taken up a couple space, just to step back a little bit and let others share as well. To continue assuming positive intent while remaining open to learning and keeping our conversation solution focused. And most importantly, just honoring and respecting privacy and confidentiality. So, what we speak about just stays with us. And then I want to pass it to just sharing a little bit about the agenda today. We're going to have some acknowledgments and announcements, and then hear a little bit about background to the terms that we will be hearing from today. We will go into the panel discussion and end with a Q&A portion. If you all have any questions, you can please go ahead and drop them in the chat throughout the conversation. We can save them for the Q&A portion. And throughout the Q&A portion, if you would like to just come off of mute and raise your hand, you're more than welcome to. All right. So before we continue, I'd like to thank the many people and organizations who have made this space and this health policy camp so successful, and just bringing their voice into this. We want to thank our community partners, all of our panelists, and we have put out invitations to council offices. So if any council offices or staff members are present, please go ahead and let us know in the chat. We also want to recognize our chat members who is a part of our community health advisory panel and is many different parents, our parent ambassadors that are part of it, and our healthcare professionals that we continue to engage in advocacy. And most importantly, our parent ambassadors who are on this call right now, but also throughout the health policy camp, as this was a 2-week initiative and we started last year. We started last year. Last year was actually our first annual health policy camp. This is our second one. And we've had a couple events so far throughout the past week and just engaging everyone. Thank you for all your support, even the in-person events and showing up. All right. So another thing that I wanted to share was that we are currently collecting some child find stories. So we are looking for collecting family testimonies through our My Child Find Storytelling campaign to better understand families' experiences, navigating early identification, and special education services. So we encourage you to consider sharing your story as these stories help raise awareness, inform policy discussions, and strengthen advocacy efforts. Especially out of today's conversation, you'll see the motive behind continuing to share your story as this truly impacts advocacy efforts and decision making in DC. So before we get started, I do want to go ahead and launch the first poll of tonight. We will be seeing 3 polls in total, and this is just so that we can get some participation from you all and hear from you all through the poll. Give me 1 second. Okay, so the first question asks you which systems have most impacted your family's well-being in the past year. So you can select up to 3 answers. So far, I know we have 15 people on the Zoom. And even if you're a panelist, we encourage you to answer this as honestly as you can. So the first one we have is mental health services, education and special education, housing, transportation, childcare, employment or income, food access, or language access. Okay. We have about 8 answers. I'll just give a few more seconds so you can finalize your answers. Okay. So far right now we have the top votes for mental health services, housing, childcare, and employment and income. I'll go ahead and end the poll and just share the results. And with healthcare being the top voted one. Yeah. Okay, no surprise there. So we're going to go ahead and actually move on to the next portion where we are going to define some of the terms that we'll be addressing throughout today's conversation. And just to make sure we're all on the same note, I'd like to pass it to Dr. Chioma Oru to introduce this section.
All right, good evening, everybody. I hope everybody's doing well. Thank you all so much for being here tonight, this evening, especially to our panelists. Welcome to our parent ambassadors. Um, so before we begin, as Danny just mentioned, we'd like to make sure that we have some shared understanding of key concepts that I'm going to unpack a little bit here. And you can find more details in the one-pagers that you'll see in the live binder. Note that I'll be adding more one-pagers as time did not permit to add some more about specific things that we may unpack tonight around how DC government makes decisions. But I'll talk it out. I'll talk it out now. Sorry. I'll talk it out now, and then you can download them later, but you can find many things on the Live Binder right now. So the first key concept, we talked about this on day one of the camp. We talked about social determinants of health, and we talked about political determinants of health. So I'm going to focus on the political determinants of health tonight, which are, these are the sets of laws, policies, funding decisions, budget decisions, and leadership, whether they be elected or appointed, that occupy government spaces that shape um, policies and the decisions that inform our lives at the federal level. But today we're going to be focused on the local level. So there are many levels of political determinants of health. And today we're going to be focused on the local climate of that. In terms of DC's local government structure, in your live binder, you'll see you can download a copy of the current DC government structure. I think the last time it was updated was in 2024, which is, what we're currently operating on. Note that once we change powers or we switch to a new mayor in the new year, some functions may change. Those are some of the liberties that the mayor has, but not much will because a lot of them are guided by local law. So you'll see that the key org charts there, in some, they're just key executive leaders that support and anchor agency functions for DC government. And they answer, and these are appointed people that make up the mayor's cabinet. So that's the deputy mayor for Health and Human Services, the deputy mayor for Education, the deputy mayor for Public Safety and Justice, the deputy mayor for Planning and Economic Development, and then who we consider our assistant mayor would be our city administrator, who administers all of key government functions. Now, each deputy mayor oversees clusters of agencies, be they, so for example, Deputy Mayor of Health and Human Services, under that body, we can find our Department of Human Services, Department of Healthcare Finance, Department of Health, right? There's just a range of agencies under that. Department of Education will find a lot of the agencies that our children are navigating, be they OSSI, uh, they under the mayor, DCPS, the DCPS chancellor answers directly to the deputy mayor of education, and then the mayor or the mayor, everybody answers to the mayor. They all serve at the pleasure of the mayor. If you see any official appointment form, that language will be used frequently, serving at the appointment of the mayor, or if it's council confirmed, at the pleasure of, council and the mayor. But then under public safety and justice, we have the Metropolitan Police Department. We have the Office of Victim Services, I believe is also under that cluster. All that is listed in that big chart there. Deputy Mayor for Planning and Economic Development, that's where the Small Business Administration, and a lot of the innovative technological things go down in the planning and economic development. And as I mentioned, the city administrator has an aerial view over all the agencies and their functions, and it's the key like intelligence that monitors progress, allocation of funding, key performance indicators. So they hold a lot of the data of the functions of the agencies, and so the city administrator is a critical actor and a key ally for the mayor. So different government agencies have different jurisdictions and levels of authority. They translate laws, they implement budgets, they help highlight policy priorities, and they report directly to City Council each year when we have our performance oversight hearings, and then when we have our budget hearings. So I consider that their report card when they get their progress reports from us constituents, from ally advocates, many of whom are here tonight, are some of our most seasoned, testifiers that really show up to let the DC Council know what's going on in the city, how things are actually happening in the real world and not just on paper. And so things like determining eligibility, things like our referral or application processes functioning, things like staffing and workforce needs, things like contracts and grants, data collection, if certain important accessible things like language and disability access, the functions of these things are very critical to the agencies and, of course, to the democratic process during budget season that inform their functionality, if they're doing well, if they need improvement, if they need more money, if they need less money, right? Um, in terms of decision making per agency, again, that's part of why the org chart is important. You kind of see how the chain of command flows. So down to the agency level, their point of contact, who they report to direct deputy mayor in whose cluster they function under, unless they may be an independent agency, kind of like the State Board of Education, and the Ombudsman's Office for Education, and the different ombudsman's offices, the ombudsperson for health, ombudsperson for behavioral health. These are independently appointed people that may not necessarily, they're appointed by the mayor and they do serve at the pleasure of the mayor, but they operate independent and they do not necessarily fall under the chain of command to report to the deputy mayor because their function is to be, in service of the people directly. Um, just to not belabor, laws are the role of law in the DC, how agencies interface with lawmaking. A lot of the laws in which we are implementing or agencies are regulated by are decided at the federal level. And in many ways, DC is considered a state when it comes to some of the liberties that a state function may have in interpreting a law or creating sub provisions in DC code, DC's local law that may give more definition in how we can culturally understand and interpret federal law or strengthen federal law. But the relationship between federal and local law is that local law can never be less than federal law. It can only match or go beyond what federal law kind of mandates. So our agencies are taking legislation at the federal level, at the local level, and the regulations, and they are determining their agency level policies and procedures, which should also be publicly available, right? Sometimes you have to ask through FOIA requests and otherwise. Our budget goes through also a very stringent due process because we're not a state. This is where we see our most vulnerable decision making when it comes to budgets. That while the mayor does propose the budget, council does approve the budget and pushes back on things that the mayor may or may not through the budget process, which should be participatory, which is why we ask people to go and testify at city council. Your voice matters because it does shape the budget and the decisions. Um, but part of our vulnerability of not being a state is that the final decision making goes to Congress. So Congress can have the final veto power over our budget, which is not the case with other states or real states. Let me put it like that. But we do have a fair amount of autonomy, which is why we guard and protect home rule. Home rule means that our agencies and our city council and our mayor get to make all these decisions and implement those decisions in the ways that I've just kind of explained. And I hope that our panelists kind of deepen things that I'm just kind of glossing over at length. I always say Mark Lavoda is my teacher on the budget process. Like I get schooled regularly and I miss our sessions, but you have some very key knowledgeable people that are going to break it down for us here. So just in sum, in terms of the budget process, the budget determines again how public monies coming in from our tax dollars, coming in from federal grants, and other federal monies are distributed across agencies and programs, contracts, grants, and services. It directly affects our quality of lives, which is why they are political determinants of health. So our budget cycle goes from October 1st to September 30th. That's typically the cycle. Now, we've had some well, that is our budget cycle, but we've had some cycles in which our decision making kind of goes off. Sometimes the budget is introduced in March, sometimes it's introduced in April. I think the year of the one big beautiful bill, we didn't get the budget till May, I believe, if my memory is right. So that pushed our budget process to go all the way into the middle of the summer. But that's really not that typical. Oftentimes, the budget is decided by the end of June, early July at latest. And so agencies develop their budget requests, and those budget requests are informed by the performance oversight, what council kind of gives the first report card. And then the mayor takes their budget requests, develops the budget, sends it, makes it public, makes this big announcement. She announces the budget. Everybody's blood pressure is rising because, there's always something off there. And then council reviews the proposal. We all come together in a democratic process to say, we need more money here, take the money away from here. And that becomes then what council goes back and deliberates as a whole body to then, make a decision. The mayor can have some veto power. I hope Mark and Patricia really break us down in terms of that. That's a nuance there. And then it goes to Congress, of which then they also have veto authority. And if all goes well, then our budget is finally approved. Um, DC's our legislative process is maybe a little different in that we do get to pass laws um, based on home rule per whatever authorities that other states may have. But of course, Congress has authority over any decision we make in the district because we're not a state. So, but generally, how our legislative process happens is there's an issue, a real issue. This is why each council member has constituent services. They should have ears on the ground. They should have ears in the community, knowing what's going up, what's going down. They should have an open door policy, even though now you make appointments for, I guess, safety and security reasons. And the mayor also has their constituent services people who are boots on the ground, ward by ward, on a citywide level. Now, in the city council, if you're a Ward 4 city council, your boots on the ground are limited to Ward 4. If you're at large, your boots on the ground are probably going to be limited to whatever committee that you're leading or very active under. But the mayor has total jurisdiction over the entire city and how we identify the issues, we understand the functionalities of what's working and what's not working. But once a problem is identified, this is when we then create what we know to be policy and public policy. Um, Anyone can propose a policy change. Our most effective advocates and the allies that our council highly depends on are the DC Behavioral Association, the DC Primary Care Association, DC Fiscal Policy Institute that has come to visit with our parent ambassadors. They help with creating language, with understanding key problems, doing research on what's going on in other states. These are highly dependable partners with our agencies and our city council when it comes to the policy making process. They serve boards and commissions, and so do we. We all, as citizens, PJE, as the Parent Training Information Center, you as leaders of your households can also participate in those very nuanced and highly demanding partnerships that are required to propose a budget, propose a law, propose a language for a law, to read a law, make sure that whatever they have finally put on the books actually reflects what we want to see for the people of District of Columbia. And then once that's kind of done on the kind of the inside, sometimes you'll see like a law is co-authored. So that's where the politicking happens. Somebody is buying into another person, somebody introduces it, and then they get this other council member to co-sponsor it, which strengthens if it's going to pass. And then it becomes public, and then they debate it and they hold public hearings, which would then hopefully include, like I mentioned, people being able to give feedback on the language of the law, people being able to push back and saying, we don't want this law for whatever reason, and kill the bill. You've heard when they say they can kill a bill. The bill can die right then, right? If it doesn't pass the smell test at the public, once it's introduced to the public and it goes through the public process. And then, and then committee review, committee votes, there's all of that nuancing of the decisions, and then it gets passed. But then there's also the nuance of a budget, a law getting passed or policy getting on the books, but then does it have a budget? Can that budget be able to give it legs and wheels to move, right? These are important things that go into the letter and the authoring of the law. These are the things that make a law a good law, or a bad law, or okay law. And of course, the mayor can intervene, subversively and, through the due process, through another veto process. And again, it will go to Congress, hopefully for passive review, considering that we tend to, there's a common practice these days that they respect our legislative authorities in these ways, but we're that is not guaranteed, and any president and any Congress can really make that process more painful, which is why we keep asking for statehood and then a law is implemented. And I've said a lot. I'm going to stop. I'm going to pass it back to Danny, or I'm going to pass it to Emil, so that he can introduce the speakers and you get to hear from our brilliant panelists. Thank you.
Appreciate you for breaking that down, Chioma. Man. How's everybody doing today? My name is Emil Hudson. I'm a parent organizer here at AJE, and it is my pleasure to introduce our panelists for this evening, who are going to help break down, how we turn a lot of our needs in our community into actual policy, and how that policy is implemented. So first, I want to start off by introducing Patricia Quinn, who has more than 25 years of experience advancing the health and well-being of children, youth, and families through public policy analysis, advocacy, and organizing. As Senior Director of Government Affairs and Policy at the DC Primary Care Association, she works to ensure the financial sustainability of community health centers, leads efforts to strengthen accountability across DC's health ecosystem with a focus on behavioral health, maternal health, and health equity. So thank you. We're excited to have her here. Next, we're going to have Mark Lavoda, who has served as Executive Director of the District of Columbia Behavioral Health Association since 2016 and has held leadership roles on numerous district behavioral health and Medicaid advisory bodies, including as chair of the Department of Behavioral Health's Behavioral Health Planning Council and the district's Medicaid Medical Care Advisory Committee. Before joining DC Behavioral Health Association, he spent 11 years leading the grant and contract applications team at Catholic Charities of the Archdiocese of Washington, and previously served on the District Opioid Abatement Advisory Commission and the Mayor's Healthcare Workforce Task Force. Sandra Cuesta is a Student Services Coordinator at Brea Public Charter School, where she supports adult learners and families in accessing education, resources, and pathways to opportunity. Originally from Piura, Peru, Sandra came to the United States in 2015, began her journey at Brea as an adult learner, and now draws on that firsthand experience along with her child development credential from Brea and case management certification from the University of Maryland to help students and families succeed. Lastly, we're going to have Jenny Saldana, who is the DC Outreach Coordinator at First Shift Justice Project, where they educate pregnant people, caregivers, and parents about their workplace rights through bilingual Know Your Rights presentations in English and Spanish. They are passionate about empowering communities across the DC, Maryland, and Virginia region with the knowledge and tools to advocate for themselves at work. So, I appreciate you all joining us. And so just please join me in welcoming them by dropping a reaction or emoji, in the chat just to show your appreciation. And I'll pass it back to Danny.
Thank you, Emil. Okay. I'm loving the emojis. Welcome, everybody. All right, so now we're going to begin with the first round of questions. We'll start with healthcare and get a little bit of background there to get to hear from Trisha. We'll then move into behavioral health and hear from Mark, then pass the mic over to Jenny. So you can tell us a little bit more about paid family leave, and ending with Sandra to tell us a little bit more of the work that she is doing at Brea and educating families through policy education. So without further ado, Trisha, let's begin with healthcare. Families often experience policy decisions through their ability to access care, navigate systems, and receive the support they need. So, Trisha, can you tell us what are some of the biggest healthcare policy issues currently affecting children, families, and communities?
Thank you so much to all of you for being here, for allowing me to come and share some of what we've been working on at the Primary Care Association. I think people have been pretty aware that, I will say, I've been at DCPCA for over 12 years. For most of that time, DC has been an incredible leader in health insurance coverage. We've been in a place pretty much where anyone who needed health insurance in the district could get it. But since January of 25, that all began to change, and that change is really accelerating right now. The coverage gains that DC led on are eroding pretty significantly. I will say mostly due to changes at the federal level, either directly or indirectly. The Alliance program in particular for low-income residents who don't qualify for Medicaid really became a target for cuts in the FY26 budget for a bunch of reasons. One being DC policymakers somewhat preemptively worrying that it would draw unwanted attention and would impact funding for other district programs, particularly for our larger Medicaid program. And then the general climate of the federal workforce, federal funding through the Trump administration really meant that district revenue, the money that we have to spend on the things that we care about, has struggled to keep pace with rising costs because we've got fewer people working. Our unemployment rate is up. Changes in district revenue base mean that policymakers begin to look at big ticket items like healthcare for program cuts. I don't want to go into like incredible detail about some of the ins and outs of some of the changes, but I think broadly we can say we changed the income eligibility for both Alliance and Medicaid. So we made it so that some of the people who used to be eligible at like still very low income, but somewhere between 138 and 212 of federal poverty level were no longer eligible. So we shrunk the pool of people who would be eligible based on their income for both of those programs. We also, in the case of the Alliance, we limited the benefits for that program. We limited the medications for that program and other services that were available, even to the people who remained in the Alliance. I'm happy to take any questions that anybody has about the details on like what changed. And I am really glad to say that some of those bad changes are going to be undone beginning October 1 of this year. So October 1 of last year, we made some really painful and negative changes. Some of those are going to be corrected beginning October 1 of this year. So for folks who don't know, the Primary Care Association really works and advocates on behalf of, community health centers in the district, community health centers and their patients. So for community health centers, the impact on them with these changes, first and foremost, I would call it kind of moral injury to the people providing care in community health centers, because they were confronted with patients who had needs. Primary care can do a lot, but it cannot do everything. And they had patients who were losing healthcare coverage where they could still provide the primary care to that patient, but they no longer were able to refer that patient to some of the specialty care that they might need. Their patients weren't able to necessarily get some of the medications that they needed because they no longer had insurance to pay for that. And that has put healthcare providers in a really painful position of having to say to somebody who used to have insurance, we can't get you in to see that specialist for cancer care. We can't make sure that the medication that was really helping you manage your chronic illness, you don't have access to that anymore. So there was that kind of difficult situation for the providers to be in. But there's also a financial impact on health centers when more of their patients don't have coverage and don't have the resources to pay for a primary care visit. We're going to keep seeing everyone that we possibly can, but there's no way that erosion in coverage doesn't mean financial impact on community health centers. And what do you think the biggest expense for community health centers is? It's staffing. So when the financial stability of community health centers is impacted by these changes, eventually it has impact on staffing. We are right now not seeing limitations within community health centers for patients, pediatric or adult new patients. But as those new eroded coverage rules go into play, we are really concerned about what that means for access for patients. So I talked a little bit about what already happened. I'm sure people have started to hear about what is going to happen, which is beginning January 1 of 27, some people on Medicaid are going to be required to either be exempt from work requirements because of caregiving responsibilities or because of chronic illness that makes it impossible for them to work, or they have to show that they are meeting that work or community engagement requirement. We have not had that in the Medicaid program ever in the district, and most states have never had a work requirement for that benefit. So we're watching really carefully the SNAP rollout of work requirements, and there's a lot to be concerned about in that regard. We fully expect that even people who are meeting the requirement or who do have legitimate exemptions are going to lose coverage. And I would say my last big concern, there are so many, is recent changes at the federal level on public charge. We think that public charge relates to what public benefits has an individual access that might impact their ability to get a green card or and be on the path to citizenship. And the Trump administration has made some changes to public charge that will give a lot of discretion on what counts, including healthcare potentially. So chilling effect for that is a real danger to our population and who is seen within health centers. Did I answer the question, Daniela?
No, thank you. Thank you, Trisha. And I appreciate how you were giving the background to what has happened since 2025, the introduction of OHR and the federal level, how it's impacting the district. And then also just highlighting a little bit of more barriers that are to coming January 1st, 2027. So this next question, just as you were speaking about the bigger impact, let's focus in a little bit more with the direct impact that families are seeing when accessing care, especially as specialty services are being gutted. How do decisions made at the policy level translate into real experiences for families seeking care?
Yeah, I thought about that when you shared your questions, and I think for me, for many people who are advocating in the health space, it's really difficult to reconcile decisions that eliminate healthcare access with the values that we associate with, like, who are we in DC? Policymakers make these decisions that create kind of winners and losers, like what is, there's a finite pool of revenue, and what gets funding sometimes creates that environment of scarcity and winners and losers. But I think we really have to be very vocal and very visible that healthcare just cannot be part of that equation. I know we ask a lot of parents, of families, of individuals when we ask you to come out and share your stories and talk about the impact of having healthcare or not having healthcare on your ability to live, literally, in some cases, ability to live healthy and with well-being. And I think, without a doubt, people's willingness to do that in this last several years and in the coming years has been the difference between how policymakers view where healthcare is in that level of need and importance for families. But I do think it is on the kind of professional advocates, and by that I mean people who are paid to do this work, because a lot of people who've been showing up for healthcare, that's not their day job. they have other work, and they are coming to the policymaking process using their own time. I think that the professional policy advocates, we need to be responsible for presenting strategies that make the health system more effective, more efficient. You talk about sort of the head and heart rule in advocacy. And the heart piece is those stories of people who have experienced care for, in our case, in community health centers, and had positive experience with that care. They know what it means to the well-being of their family. That's the heart piece. And the head piece is how do we look at policy and present possibilities for how we do this in the district. It has to include strong investment in Medicaid and strong investment in the Alliance. But we need to do a better job of the health system, working collectively and creatively about how we care for every district resident. Mark and I have been part of conversations among healthcare associations, like what's the base, what is the baseline of what we're going to commit to as a district in providing care to people. And that might look like a more directed or structured community benefit system. All the nonprofit hospitals, all the nonprofit educational institutions in the district have an obligation as part of that nonprofit status to reinvest in their community in some specific ways. Maybe we need to be taking a closer look at some of that and ensuring that the priorities of community members, people who are on Medicaid, people who are on Alliance, or people who need those programs but can't access them, what are their priorities? And how do we make sure that what we're doing in the health system is attentive to that? Because I want the stories that people are bringing forward to have that context for policymakers. And yeah, that we are doing our part to surround those personal stories with a context of policy ideas that do them justice in some way.
Thank you, Tricia. I do want to take it back a little bit. I know Chioma gave us a little of a background to how decision making is done in the district. And so as we are continuing to bring in more families into these conversations, specifically the healthcare system, could you talk a little bit about what should families understand about how healthcare systems are shaped by government decisions? I know you talked a little bit about the professionals. Let us know.
So I think Chioma did a great job of talking about sort of the branches of government and what their roles are. And in a community like the size and scale of DC, what happens, through the mayor's office, her or his priorities, and the way that shows up in state and city, what I call, Chioma said, we function as a state. So in those agencies that are part of any mayor's administration matters a lot. And policy is driven in many ways by those unelected policymakers, right? So the mayor is elected, and who she appoints, we're sort of hoping for good choices in that space. And as we come to a new mayor beginning in January, influencing the choices of the mayor for who leads organizations, who leads healthcare finance. That's where policy on Alliance comes from. That's where to the degree we have control, policy on Medicaid comes from. I'm sure Mark would have a lot to say about, who should lead the Department of Behavioral Health. Those decisions matter quite a lot to what happens relative to policy. And we often think more about council and the budget, and those are very, very important as well. But I don't want to undersell what it means to have a new mayor who gets to make these choices on our behalf, right? She's going to be picking if it goes the way we expect it. On our behalf, who's going to lead these critical agencies in the district. So I think engaging once the mayor-elect is ready to start those dialogues. I mean, I think we need to be at the table. Families, individuals, parents need to be at the table, saying what they need from those leaders too, So I'm thinking a lot about that. How do we say what we need from those leaders and make sure we get it? Because it matters so much. And they're not elected. So we gotta have our voice at that table. And then certainly showing up to council for those oversight hearings that Chioma talked about. I like the report card idea. It's a report card on how are they doing. And we try to come to the table, here's what worked, but also here's what didn't. And this is where we need improvement. And, community voices in that conversation are really needed because they're the real world of what's actually happening. And I can know what I try to tap into that, but I don't do nearly as much of it as I wish I could. So we really rely on people coming forward and being part of that dialogue with council in oversight. And then it comes down to resources. So the budget fight is going to be with us for at least the next several years, if not longer. We didn't always have to be in that fight. As I said, in my first probably 10 years, our fight was not a budget fight, but now it is. And so we gotta show up for that too.
Thank you, Trisha. I really appreciate how you make that note of families being and just advocates having a seat at the table to really hone in into their experience and highlight that, putting it to the forefront. Because as many people are in decision making or in government, they are far removed from the direct experience that many caregivers and people of the district may face. So I appreciate it.
Thank you, Daniela. The last thing that I'll say is I am in my however many years of doing advocacy work, it is absolutely a truth that policies are best made or changed by the people most impacted. That's how we get to effective policies. When we fail to do that engagement and fail to fully understand what this means at the community member point, we're not going to be as successful in what kinds of policies we put into place. So keep showing up and hold us accountable, the sort of professional advocacy class, to taking that deeply into consideration on what we're promoting, that we have to, if we're going to be putting forth policies and implementing policies, that we are doing that with the full knowledge of people with context expertise and in what's really going to work.
Beautifully said, Trisha. Thank you. All right. So now we'll transition over to listening and hearing a little bit about behavioral health. So I'll pass it to Mark, where we can listen to a couple of how families are encountering these complex systems. So the first question to you, Mark, is what challenges are you seeing in behavioral health access and services in the district?
Well, thanks. I appreciate the opportunity to be here. Appreciate everyone taking the time to be part of this conversation. We are at a pretty bad point for the district's behavioral health services. I testified in the spring that this past year was one of the three worst years in the past 20 years in the district's ability to deliver effective behavioral health services for the people who need them. And I can't say that things have gotten substantially better in the 6 months since I delivered that testimony. Um, at the same time, people have greater need for mental health and substance use services than any time in recent memory. We see that the prevalence rate of serious mental illness is higher than in any time in recent memory. The prevalence rate of overdoses, the prevalence rate of suicidal ideation, the prevalence rate of serious emotional disturbance for our kids, the prevalence rate for general substance use disorder are all much higher than any time in recent memory, some of them astronomically so. So it is a really bad time for the healthcare provider network to be falling short so much. Um, Unfortunately, all of the stuff that Tricia said about healthcare in general is also true for behavioral health specifically. And then behavioral health has its own additional problems because there is so much need, there is so much unmet need, and because frankly, the district government has not done a good job of how they choose which organizations are responsible for delivering behavioral health services. Um, I want to give a lot of credit to Tricia's members, the federally qualified health centers in particular, for doing a really good job with really limited resources to try to address mild and moderate behavioral health conditions. But they can't address the most serious needs, the most severe mental illness, the most severe substance use challenges, using only the resources that their staff members offer, using only the kinds of services that FQHCs are designed to deliver. We need specialty behavioral health also to work. We need home and community-based behavioral health also to work. And right now we have a system where largely you can't be a good actor. You can be a good faith actor or you can be a bad actor, but it's not actually possible to do the work correctly without cutting corners somehow. And I name bad actors because we have an active and pervasive set of organizations that call themselves behavioral health providers, but they are actually just in the business of fraud and incidentally have figured out how to be especially good at fraud in the behavioral health delivery system. And so there is a real concern that that means that we're seeing the district government and district taxpayers be robbed of the financial resources that we need to operate these services and systems. And then we're not investing in the organizations that are trying to do the right thing, but that can't afford to do the right thing because the people who are coming to them are coming to them not getting the care that they need for too long, sicker than they ever needed to be, off of the medications that they previously had prescribed, and really desperate for a kind of help that previously we had specialty providers that were strong enough to help keep those folks stable. And now that's just not the general expectation. I don't want anyone to take the impression that there's no treatment available. There is. I don't want anyone to have the impression that there are not good faith actors, that there are not organizations working very hard to do this work to the absolute best of their ability. There are. But people have to be discerning about the kind of care that they seek. And if they're not getting the care that they need to march with their feet until they find someone who's actually willing to work with them and their family and whoever else is part of their support network to take care of them. And that is a hard thing for people to have to go through when they are already struggling with whatever that illness is, and also usually some sort of social barriers to accessing the care that they need or having the kind of home environment that makes recovery sustainable or having the relationship capital to have the support interpersonally, not from a treatment provider, but from a friend, from a neighbor, from a loved one, to be able to help them walk through the journey that they're going through. So it is a mixed message here, clearly a tough one, clearly a sad one, but also one where I don't want people to lose hope that there are resources that are available, that there are organizations that are working very hard to deliver the best possible care, even within all of those constraints. We have to keep doing the policy work because we have to demand that the government steps up and does its job. The Department of Behavioral Health has to do a better job of governance and oversight of its own provider network. The Department of Healthcare Finance has to figure out how to get these fraudulent actors out of the system and how to pay adequately for the services that are still needed from organizations that are appropriately put in place to do the work. And all of that is going to take a lot of screaming and yelling from people to demand that we get the care that we need for some of the district's sickest and most vulnerable residents.
Thank you, Mark. You getting some love in the chat, and I'm loving it. Calling it for what it is. And so this next question, we just want to hear a little bit about how do the policy decisions and funding priorities impact the availability of behavioral health supports, as you were also sharing, outsourcing.
Right. So, I mean, first, like I said, everything that Tricia said for general healthcare is also true for behavioral healthcare. When people don't have insurance coverage, then provider organizations face terrible choices. They either have to say no and not provide the care, or they have to provide that care at their own expense. And lots of organizations aren't making enough money from the people, well, from the insurance companies that do pay. And so the Charity Care Fund is running pretty low. And so, that is a real financial challenge. And then, as Tricia also pointed out, when organizations face persistent financial challenges, eventually they have to make tough staffing choices. And I will say, we've already got organizations that are trying to figure out how to get by without a deputy financial officer for their organization to help make sure that they're managing expenses well. They already let go of the population health analyst that was going to run a registry and say, hey, these folks don't have their diabetes under control. We should get them into a primary care appointment. Every available dollar is being directed to frontline services and care, and that's great. But when you don't have the supervisory infrastructure, when you don't have the administrative backup to make sure that your organization is pushing the support that's needed to that frontline workforce, then they can't do the effective job that we want them to do either. And so that's the real challenge that we have to figure out how to address for this system right now, is how do we reinvest in the organizations that have really tight financial margins, that have already exhausted every last dime of their credit limit, and still have people who are really committed to doing the work, to doing the right thing, to delivering excellent care for people who really need it.
Thank you, Mark. And so we'll move to our last question. And for this one, I know that you've done so much work advocating and being in the front lines with DC Council, providing some recommendations to behavioral health. So could you just share what changes are needed to create stronger, more responsive systems for families?
Yeah, so I've got a couple things that I'm going to point people to instead of just trying to remember off the top of my head all of the things that I might want to say. One, because I know that this is a group of parents and families, I want to point to the work that we've done with Children's Law Center, Children's National, as well as community groups like Parent Watch and Total Family Care Coalition on a path forward report for our children's public behavioral health system. It's really important that, again, as Tricia said, we listen to the people who are actually living through this, bring their experiences to how we think about the kind of policies that are needed. And so this is work that we've done together with a lot of stakeholder input from directly impacted people, from their families, from the broader community, and from these different stakeholders that are delivering legal services, behavioral health services, hospital level care, and making sure that we make a good set of policy recommendations. So that's one set of recommendations that I want to be sure that people are aware of, and things that I think can really help our children's system to deliver the kind of behavioral health services that we want and need. I will particularly just draw people's attention. There is a table on page 80. It's numbered page 80. It's the 81st page of the PDF. But there's a table that shows our continuum of care. And we want to make sure that people think about behavioral health comprehensively. We need to do prevention work. We need to do early intervention work. We need to do treatment for people who need treatment, and we need to do recovery support to sustain their recovery. And that chart points out where there are just gaps, really big gaps right now, where there's no care. You don't see partial hospitalization programs or intensive outpatient programs at all. There's no extended observation unit for kids who are in crisis. You can either sit in an emergency department or you can be admitted inpatient, but we don't actually have some place for you to go just to stabilize. And I will also point out that while this chart does show that there are a lot of resources that are available, some of them are falling apart. DC MAP doesn't have funding to make it to the end of this fiscal year. The primary project isn't working nearly as effectively as it used to. Healthy Steps almost got defunded during this budget cycle, and without extensive advocacy, it wouldn't exist anymore. So these are all real challenges and dangers. We have to fight against having these programs destroyed. And I will also say we have to fight against DBH saying that they're going to do things in-house that they don't have the capabilities or the capacity to do while they yank resources out of the community. But we also have to fill some of these gaps. These are still real gaps, and we still have to work to figure out how to fill them. Thanks, Chioma. So transitioning, and the second document that I'll share is our broader District of Columbia Behavioral Health Landscape and Opportunities document. We've just released this to help support the next mayor and the next council, because the council's changing too, to think about what the landscape looks like right now, to think about where some of the biggest gaps are and what some of the biggest opportunities are. We know that behavioral health services are actually solutions to the things that these folks all got elected to address. You want to talk about how you are going to address emotional distress. You want to talk about how you're going to address economic insecurity, federal policy changes, community safety. Well, you have to think about how you're going to support people's emotional well-being. Think about how you're going to help them to deal with the challenges that they're facing with the tools that mental health and substance use treatment provide, while we also make sure that people try to get access to the other care and resources that they need. in this policy guide for, again, for the mayor and for the council, clearly we have to call out the fraud. And clearly we call out a number of specific policies, but I'll also reinforce what Tricia said. We need leaders in district government policymaking roles to be the kind of leaders that will make these hard choices that they're going to have with the right people in mind and with the right people at the center of the conversation. They need to be able to articulate a clear vision and enact that vision. They need to engage in collaborative change, actually talking to all of the impacted stakeholders. And they need to make decisions with transparency and with accountability. They don't just get to take credit if they did something wrong, but we still figured out how to make it work anyhow. And they don't just get to pat themselves on the back if we make something work right, despite whatever they might have happened to have done at the same time. It's time for us to find leaders that are going to accept that things are broken right now and that are going to have the willingness to engage in the hard conversation about what it's going to take to fix it.
Thank you, Mark. We appreciate you just giving us these beautiful links. I just want everyone to know I'll go ahead and share those links afterwards via email. And just thank you again for the time you're dedicating into putting these recommendations forward to everyone. So as we can, and just for sharing with us today a little bit more about behavioral health. So, as we continue our conversation about health and the policies that shape it, we must recognize that families need workplace policies that acknowledge caregiving responsibilities and create the conditions for them to thrive. So, next up, we're going to hear from Jenny from the First Shift DC project, and I want to go ahead and ask Jenny if you can share a little bit about why are workplace protections and paid family leave important parts of family well-being.
Yeah. Good evening, everybody. Very happy to be here. Um, yeah, in my role as outreach coordinator, as it was sort of shared in my bio, I do a lot of know your rights presentations. So I, go into community settings wherever, people sort of welcome me to do that sort of legal education to talk about, what is DC paid family leave? What is FMLA? What are your rights to job protected leave, pregnancy accommodations? And so I think from what I've seen in my experience, that work has shown me how important it is because the law is so confusing. And by creating that information by sharing it in a more accessible way, it supports the most vulnerable workers, people who might be more easily exploited, and also just so that folks feel more comfortable advocating. I think I've again seen in my role folks who have told me, I tried to work with my employer to get the accommodations I needed for pregnancy or trying to take time off for caregiving, and it was just frustrating. So I decided to leave my job. And that is unfortunately a really common reality is that people decide I can't handle this, which is understandable if you're dealing with, health issues, if that's your own or, caregiving for somebody, to have that added stress of now I'm fighting with my employer, to get what I need so that I can be healthy, so I can take care of the well-being of my family. And also trying to keep my job, protect my job. And so I think, again, the legal education is really vital so people know what their rights are, and feel more confident in advocating for themselves and, just providing that information in a way that is more, you know, um, uh, accessible, and just making sure that, especially when changes happen, people are aware of that. And I will also just add that, I mean, I, talk to people about DC paid family leave, and even to this day, I have folks who don't realize they're eligible, who don't realize that this is, a program that they can apply for. So, there's work to be done to always educate our communities, and I'll share a little bit about sort of the future of that program in particular.
Thank you. So, Jenny, can you share what are the threats that exist to maintaining or expanding paid family leave protections in DC, especially given the recent proposals of the FY27 budget?
Yeah, absolutely. So just some context as to, the DC Paid Family Leave Program. This is a program that provides income replacement for workers who work in DC. So you don't necessarily have to live in DC, you just have to work most of the time in the city. And it fully came into effect in 2020. So it was passed as a law a few years before that. And so it's only been around, for a few years. And so in this past budget cycle, Mayor Bowser was proposing cuts that were pretty stark. So in the DC Paid Family Leave Program, there are four categories of leave, which is family, medical, parental, and prenatal. With the exception of prenatal, the other three categories, as of right now, provide 12 weeks of benefits. And so the proposal, in particular, was cutting family leave down to 6 weeks and medical leave down to 8 weeks. On top of that, also decreasing the amount people would get weekly down to $1,000 a week. And lastly, putting a freeze on new claims for family medical leave, which would have meant people couldn't apply for those benefits if they weren't already, receiving it. And so, of course, this was really concerning for my organization, but also, lots of advocates because, having this program is really important to the health of families, people's ability to take extended time off and have some sort of financial support. And so, thankfully, we were able to restore some of that with the FY 2027 budget, but not fully. So, ultimately, what was passed and will come into effect in October, come into effect as of October 1st this year. So that weekly benefit will decrease slightly, and medical leave, instead of being 12 weeks, will be 10 weeks, and family caregiving will go from 12 weeks to 6 weeks. Thankfully, the freeze was removed, so folks will still be able to apply even if they haven't previously applied. And parental and prenatal leave was left alone. But ultimately, this is still very frustrating because that is less time for workers to have access to these benefits, particularly if you are somebody who is working and have a serious health condition, a chronic health condition, or if you are someone who's caring for, a family member or a child. And so, we do feel hopeful with the incoming, potential administration next year, and just, how thinking about how we can really advocate for restoring this program.
Thank you, Jenny. And I appreciate you also naming some of the groups of working families that are going to and are being affected by these changes. So the next question is, what accountability mechanisms should the DC Council or the mayor's office strengthen to ensure paid family leave remains fully funded and accessible?
Yeah, so with the DC paid family leave, what was sort of the frustrating part of it in particular is that the way it's funded is that there's a dedicated tax that DC businesses pay. And in 2025, that tax rate was increased, and there was a new rule introduced so that if the chief financial officer certified that the funds were there to run the program, access funds could be directed to the general fund. And so what is sort of happening is this excess money, which I sort of say in quotations, is just sort of being redirected to cover other budgeting gaps, which I think, again, is a confusing aspect to this, and I think breaks trust because they've, cut the benefits. And so that doesn't really, that does not show, right, that they're covering the full program. And so I think that that's definitely one area where there should be a mechanism for, how we hold the mayor and the DC council accountable, whether that's, some sort of accountability measure, to stop them from cutting benefits, when there's sufficient funds, or, allowing there to be, conversation. So that's definitely one thing. And then what has also been on my mind, and I think, with the previous panelists, uh, I feel it sort of relates, which is just like a general conversation around how every year, right, everybody's sort of fighting for funds in the DC budget. There's so many important programs and social services that it often can feel like a losing battle. And so just thinking about how we can, moving forward, get from a place that goes beyond scarcity, like with DC paid family leave, for example, we that was not able to be fully restored. And that's sort of, I feel like a theme I've seen with the DC budget of things not sort of being partly restored. And so we're always sort of fighting little by little and not really gaining much. And so I think there's no really, perfect answers for that, but definitely wanting to think beyond, again, that scarcity, and how can we actually get to a place where programs are fully funded and can thrive, and expand. I think, again, in the case of DC paid family leave, um, there seemingly could have been ways to expand that program, or at least maintain it as it currently is, and instead it is being cut. And that really hurts, particularly people who work in places that don't have, a paid leave options. Some people might work at a place where that is offered, but DC paid family leave, because it is a government program, can support those folks who don't have that sort of access. And so now, again, less benefits for folks who might be dealing with, really serious health issues, might have a child who's disabled and needs, has frequent appointments, or they just need to take extended time off to, to be there. And so again, I want to remain sort of hopeful for the future, but I think there's definitely in this case, conversation that needs to be had about, the mayor and DC council sort of using these funds in ways that, if it's a dedicated stream, what does it mean when we just sort of shift funds without there being a conversation that involves, the community?
Thank you for those points, Jenny, and agreed. As even the Zoom question, the first Zoom poll that I threw out there asking which systems have been most difficult to navigate. And with the many changes happening to so many social safety nets within the district, it's directly impacting families. So now we're actually going to hear from Sandra. And I just want to give everyone a reminder that if you click on the three dots, and you look for the the globe emoji that says interpretation, you can go ahead and click English so that you can hear the presentation. Let me know if anyone's having any trouble. You can also reach out to Javier and Gabby, who are interpreters tonight. Okay. All right. So Sandra, your work brings these policy conversations directly into the community and how they're understanding so many of this decision-making process and the changes happening that are directly affecting them. So as you are firsthand experiencing this, can you tell us a little bit of what this looks like in practice? So how are the changes in healthcare coverage affecting families' access to care and services?
Hi, everybody. Yes. So, as a parent, I work as a Brilla public charter school, and most of the families that we have, they don't have access to health insurance. And as a student services coordinator, we have to find ways to help them.
Incredible. Sorry,
Yeah.
Sandra, to interrupt you. Do you prefer going ahead in English? Because we can always
Oh, I
do
can
the,
switch to Spanish. Yeah, that's fine.
yeah, speak in Spanish and we'll do the interpretation in English.
Okay, okay, thank you. So, yo creo que en esta área ha sido muy difícil para nosotros conectar con los servicios a los estudiantes. Ah, hemos visto cómo nuestros estudiantes han tenido muchas barreras sobre cómo entender el sistema de salud aquí en Estados Unidos. Ellos no entienden cómo funcionan las políticas, no entienden de los cambios que están habiendo, no entienden lo que está pasando. Ellos reciben letras del seguro explicándoles los cambios que están habiendo, pero realmente ellos no lo están entendiendo por el tipo de traducción que usan, por la terminología que se está usando en las cartas que ellos reciben, que al final ellos siguen el mismo punto. ¿Qué significa esto? ¿No? ¿Qué significa esto que estoy recibiendo ahora? Nosotros nos hemos tomado el trabajo de tratar de explicarle a los estudiantes lo que está pasando, los cambios, las políticas, para que ellos sepan en cómo los afecta directamente, ¿no? Esta reducción de este budget a ellos realmente les afecta. Por ejemplo, ellos no entendían que decía en esta carta en la parte cuál es el nivel de pobreza, cómo los afecta a ellos, ¿no? ¿Qué significa para ellos, si son elegibles o no todavía? Entonces nosotros hicimos un chart poniendo qué significaba para ellos si todavía eran elegibles. Por ejemplo, el año pasado, una familia de 4 personas, cuánto ganaban para ser elegibles y qué significa eso ahora en el 2026. Entonces, para una familia de 4, que antes el límite era de $5,000, ahora el límite es $3,000, perdón. Entonces, ¿cómo es eso posible para ellos, una familia de 4, mantenerse con un salario de $3,000 para ser elegibles? O sea, no es factible para ellos. Entonces, después de explicarles, ellos llegan al punto de qué está pasando ya, la frustración de no puedo tener seguro ahora, no puedo cubrir un seguro privado, ¿cómo voy a hacer ahora? Y por otro lado, hay otra opción, el Health DC Plan. Ellos tampoco son elegibles en su mayoría porque no cuentan con un seguro social. Entonces ellos están ahora en el limbo de cómo vamos a poder cubrir esto. Nosotros también el año pasado, al inicio del año escolar, nos pusimos una meta de que todos nuestros estudiantes tuvieran acceso, por ejemplo, a District Direct, que aprendieran a usar District Direct para poder ellos mismos manejarnos su cuenta, de tener cuándo ellos pueden renovar su seguro, cuándo ellos pueden poner verificaciones, porque lamentablemente para ellos ir a las oficinas, a la Taylor Street, por ejemplo, para hacer una aplicación es realmente complicado porque no los tratan bien. las personas que trabajan ahí realmente no les dan el apoyo y no les dan el acceso al idioma que ellos necesitan para entender la información que están dando. Entonces, pero nos hemos visto con otra barrera, que muchos no cuentan con internet, no entienden cómo manejar la aplicación. Inclusive yo, por ejemplo, cuando he ayudado a estudiantes a poner aplicaciones, que eso lo hacemos todo el tiempo, los cambios que hay afectan mucho. Incluso para mí me cuesta a veces difícil entender tantos cambios que hay. Cuando he puesto una aplicación, ellos automáticamente, si no ponen su renovación, por ejemplo, al inicio del mes, y el seguro se les vence al final del mes, si no lo ponen al inicio, ellos van a recibir automáticamente una letra diciendo de que ellos no sometieron la aplicación de seguro a tiempo, la renovación de seguro a tiempo, aun cuando ellos ya la hayan puesto. Pero ¿qué pasa? Que si la ponen, por ejemplo, una semana antes de que la fecha de seguro venza, ellos, la aplicación, el sistema automáticamente los pone en un gap de que no la sometieron, entonces no van a procesar esa renovación, aunque ellos todavía están en el tiempo de someter la renovación. Pero por haberla puesto, como no haberla puesto al inicio del mes, ya esa aplicación no la toman en cuenta. Y hemos tenido, por ejemplo, que mandar siempre correos electrónicos directamente al Departamento de Servicios Humanos de ¿por qué están recibiendo letras de que su seguro, y verificamos, su seguro está cerrado? No procesaron la renovación porque no la pusieron al inicio del mes y aún estando dentro del periodo. Entonces ya no existen las prórrogas, ¿no? El tiempo de prórroga dentro de lo que yo tengo conocimiento de DC Direct ya no existe, porque tienen que ponerlo con mucho tiempo de anticipación. Entonces es muy, muy difícil para nuestros estudiantes tener siempre en cuenta o entender todas estas políticas. Y nosotros tenemos que hacerlo one-on-one. Llamar a los papás y explicarles de qué se trata, su seguro. Ellos ganan un poco más, ya no pueden obtener el seguro, no logran entenderlo.
Thank you, Sandra. And I really appreciate you highlighting a lot of the barriers, not only with digital access, even having internet access, but also just not honoring language access and being able to provide the given language that people need to understand in their language. But besides that, also the communication that they are receiving is heavy, heavy jargon, and needing to work one-on-one with families to really understand what these changes mean, is crucial.
Yeah,
So now,
especially we have students from Ethiopia, and they receive letters in America, and they not even understand what the letters say because the translation is not accurate. It's like, what does this mean? I don't get it. I prefer receive the letter in English, and I can translate it easy than receiving in Amharic, which is nothing. It is hard for them to understand what is going on.
thank you, Sandra. So then our next question, as you were also mentioning other communities being affected by this, how does the constant threat of immigration enforcement shape immigrant and mixed status families' use of healthcare services, especially knowing with all of the threat that the immigrant community has been facing throughout these past years?
Yeah. Yo, por ejemplo, he notado que las familias que vienen para renovar y que tienen que poner su información de social, no lo hacen porque tienen miedo. Y realmente depende mucho poner esa información en District Direct para poder recibir el seguro. Entonces ellos tienen miedo exponer su información confidencial en aplicativos como District Direct. Tienen miedo poner el social de sus hijos, cuyos ellos son nacidos aquí, tienen miedo a poner esa información en las aplicaciones. Am, También el desconocimiento de no quieren poner información o no quieren aplicar a veces al seguro porque no quieren ser contados como carga pública. Y entonces ellos tienen miedo también de que esa información sea tomada y que llegue a las manos de ICE. Porque a través de la aplicación ellos ponen dónde trabajan, se tiene que poner dónde trabajan, dirección, social, o sea, toda esa información y realmente ya no confían en los aplicativos y qué información puede ser expuesta. Y por otro lado, también ha sido difícil para las familias entender la diferencia de Alianza y Medicaid. Tenemos familias, nosotros en su mayoría, de que los niños tienen Medicaid y los papás tienen Alianza. Y con estos cambios, um, ellos no entienden por qué cuando van a un appointment, eh, luego les llega el bill, les están cobrando por chequeos, por exámenes, por la medicina y a sus hijos no. ¿Por qué? Ellos no lo entienden. Hemos tenido que uno a uno explicarles, Alianza, mira el seguro de tu hijo cubre esto y qué es lo que te cubre a ti que tienes, al revés. Tu hijo tiene Medicaid y le cubre todo esto, tú tienes Alianza y te cubre esto, que es barely, o sea, casi nada. Para ellos es, pero ¿por qué? Somos el mismo grupo familiar, antes yo tenía eso, yo no tenía que pagar, ahora lo tengo que pagar. Digo, son por los cambios que están habiendo, por las reducciones, y ahora ellos tienen miedo de ir a las citas. Yo sé que no es relacionado a la pregunta, pero hay algo que he notado mucho dentro de nuestras familias que tenemos, es que los papás están prefiriendo automedicarse porque ir al doctor les sale mucho más caro porque tienen que pagar por la medicina que antes no pagaban. Entonces ahora tienen ellos que, um, entre sus familias, gente que viene de esos países, en las tiendas pequeñitas de esos países que hay aquí, comprar la medicina que ellos creen que les va a ayudar, pero realmente ellos están corriendo un riesgo, ¿verdad? Automedicándose, usando medicinas que no son recomendadas o no están siendo dictadas por el doctor, porque ellos no sienten que no, al ir, simplemente están causando un daño grande al bolsillo porque no pueden pagarlo.
Gotta take some deep breaths. This is a very loaded conversation, and just the state of fear that so many families are in, the people in the front lines of decision making claiming to excuse the cuts happening to healthcare, specifically the Alliance program, as well, people are not needing the program anymore. They're not applying for it. Utilization is down. But then we wonder why utilization is down if you are forcibly keeping people in fear. So then the last question, Sandra, is how did you help families? I know you talked a little bit about the education that you were pouring into families, but how did you help families understand the significance in their presence and testimony in shaping DC policy decisions? And just before you answer that, I do want to highlight the work that Brilla and Diana from Spaces in Action have done to invest in educating the families that are directly impacted by the alliance changes and have been in the front lines in DC Council, showing up in meetings with DC Council, and additionally being able to tell their story in current times, especially as we were trying to support more funding to be poured into these healthcare programs, being Medicaid and Alliance. So yeah, how did you help them understand of their significance and presence?
I think this was a best year for Brilla, especially for Brilla Voices for All. Gaby is my colleague, and she is the leader of Brilla Voices for All. And ella ha hecho un magnífico trabajo en años anteriores y en este año enseñando a los estudiantes a abogar. Este año ha habido un incremento, aún con el miedo de ICE. Hemos tenido un incremento de 30 estudiantes yendo a abogar a las oficinas. Hemos ido a las oficinas de los council members, uno por uno, con organizaciones de DC, yendo a las oficinas de esos council members a decirles que ellos vean en persona y escuchando los testimonios de nuestros estudiantes diciéndoles, yo sufro de diabetes y ahora ya no puedo cubrir mi medicación. Entonces, ha sido para nosotros muy fuerte, pero también nos empoderó más. El hecho de ver todos estos cortes nos empoderó más. Hemos ido con Gaby clase por clase, creamos un timeline para mostrarles a los estudiantes el impacto de cómo se veía el seguro en el 2025, cómo se ve el seguro en el 2026 y cómo se seguirá viendo para el 2027. Ellos, al poder ver en grande cómo se ven estos cambios, ellos decidieron, ok, yo quiero hablar. Tenemos estudiantes que no están aprendiendo a escribir en español y en inglés, las cuales me pidieron que les ayudara a escribir su testimonio en inglés para poder ellos decirlo o leerlo, que alguien los ayude a leer, porque muchos de los testimonios fueron también nada más leídos. Yo también tengo la oportunidad de leer algunos testimonios y me sentí muy, no sé, me tocó mucho ver cómo ellos quieren que otras, a través de su voz, se pueda escuchar el impacto realmente que está causando, cómo ellos realmente fueron beneficiados con el seguro y cómo ahora ya ven este límite. Hemos sido también, hace poco estuvimos en el hearing afuera del Wilson Building también, con estudiantes que ellos están enfermos, pero ellos llegan ahí. Tengo estudiantes que ha tenido varias operaciones en el ojo, pero él quiere estar ahí. Él va con sus lentes negros y él está ahí con nosotros abogando. Y también, y no solo hablan por ellos hablan por la comunidad. Generar el impacto no es solamente ir a hablar porque yo necesito el seguro, sino porque también tengo familias, tengo hijos, tengo compañeros que también necesitan este seguro, que necesitan este recurso. Y básicamente este año escolar, Brilla tiene 4 sitios y en los 4 sitios ha sido un enfoque de enseñar y motivar a los estudiantes a abogar. Brilla Voices for All básicamente ha sido creado para estudiantes de inglés avanzado, pero a raíz de pasar por todas las clases, estudiantes de básico que todavía no pueden hablar inglés, queriendo abogar. Entonces ahora estamos expandiendo Brilla Voices for All para los otros niveles, creando nuevos grupos para poder enseñarles a ellos a abogar, a hablar en público, a darse cuenta de que su voz vale, ¿no? Y eso es realmente impactante. Yo como estudiante, yo comencé en Brilla como estudiante y aprendí a abogar por mi hijo. Yo aprendí ahí, aprendí a abogar por él porque él estaba teniendo una dificultad y el aprender el sistema aquí me ayudó mucho de que si tú tocas puertas se abren, de empezar a hablar, mi hijo necesita terapias, vamos a tener terapias, a quién tengo que ir, ok, ¿no? Y ver que Brilla me ha acompañado paso a paso en el proceso, es porque es por el motivo por el que sigo aquí, ¿no? Y eso queremos reproducirlo en más estudiantes, de que ellos puedan sentir el valor de que van a ser escuchados. Eso no pasa en todos lados. En muchos países tenemos mucho límite de ir a las oficinas de nuestros alcaldes, de nuestros representantes a hablar. No se hace, y yo sorprendida de que aquí puedo ir a la oficina del representante de mi guardia y decirle lo que está pasando en mi vecindario. Eso nunca lo había experimentado, y lo he experimentado yo el año pasado y este año yendo directamente allá.
Thank you, Sandra. I know you mentioned a little bit about individual advocacy as well, and I know Mark also wanted to touch on that. So thank you, Mark, for sending those amazing links. I know we have also shared out as DHCF presented with us last Thursday. They shared some of these announcements, but I'll go ahead and send those links over as well. If you all want to take a moment to click on those links, you're more than welcome to. And you can also switch back to original audio as we are now moving to the Q&A portion. I think we have time for about 2 to 3 questions. We want to hear from you all directly. So if you all have any questions, please either raise your hand or go ahead and drop your question in the chat. Javier, you okay? All right. Okay, since we don't have questions yet, I can launch our second poll that we have, and then we'll come back if you all have any questions. For our second poll, which policy issues, in your opinion, should DC prioritize over the next 3 years? And we really want to see what you all think about this. And you can select up to 2 answers or even 3 if you prefer. But we really want to hone into this question because as we are trying to be more proactive, we're bringing more family voices into public advocacy and even self-advocacy, thinking of what issues are most important to you all. All right, we got a couple responses. I'll give it about a minute. Okay. Great. All right. So I'll share the results. We have behavioral health access, Medicaid access, and housing stability being the most voted. I know we didn't touch on housing today, but even in our past conversations and other meetings that we have just been highlighting how so many of the social safety nets, even food access, and like Trisha was speaking about SNAP being currently in the process of getting many, many more barriers for families accessing them. So I'll stop sharing that. I'm gonna take a quick look on the chat. Oh, dang, Brandon. I thought I clicked multiple. My apologies for that. Okay. And I know we have one more Zoom poll question, but I do want to pause and see if I don't know, maybe our team, Chioma, or anybody else from the audience may have a question for our panelists today, or just even a reflection. It doesn't have to be a question. We would love to hear from you.
Yeah, one, thank you everybody for the brilliant knowledge. I know it's a lot to digest. We are recording these. We're going to upload them onto the YouTube. You can review them again. We are going to also, the live binder to summarize a lot of the information that's heavy digestible. But I do, every Tuesday we meet and we get into open dialogue, and I want, the parent ambassadors to feel free to just come off and just share your thoughts. If there are not questions, I talk a lot. So right now I'm going to pause and I definitely want to hear from you guys. So please chime in on whatever you're processing right now.
And actually, one of our ambassadors, not to brag, but is a healthcare expert. As much of her work is also surrounding that. You're welcome, Ty. All right. Like Chioma said, I know it was loaded topics, so I'll go ahead and launch the third poll that we have for tonight. Which advocacy activities would you be interested in participating in? The first one is contact an elected official, attend a public hearing, join an advocacy group or coalition, share my story publicly, advocate for my own needs or accommodations, learn more about self-advocacy, and the last one, I'm not sure yet. Okay, great. Give it a couple more seconds. Right. So the most voted one is attend a public hearing. I love to hear that, and also join an advocacy group or coalition. I know Mark dropped some of the advisory committees that the DHCF is accepting applications for. And then for public hearings in our newsletters, as more hearings will come in the fall, we will also offer the opportunity for anyone to join us as we sit into those hearings. And I also see a little bit about learn more about self-advocacy and just want to reference that AJE offers some trainings for families. And we also have our PLA sessions, our Parent Leadership Academy, if you all want to learn more about school and rights. Okay, so I'll stop sharing there. Um, I'll make one last call if anyone has any reflections or questions. And if not, mm, Brandon's question is, what does early intervention look like in DC? I wonder if any of our panelists would like to speak about that, and if not, we can probably pass it to a team member. Chiom, I think this might be a great time to also speak about the Child Find Story campaign.
Yeah, I pasted in the chat before. I'll paste it again. So Brandon, I don't know, are you in DC or you're asking? It would be great to kind of contextualize. So I think you're in Texas, Brandon, right? Do you want to come off mute and vocalize that where you're from so I can put it in context?
So I went through early intervention in Washington State. Um, I don't remember it. Of course, everybody who goes through it doesn't really remember it. But what I'm just asking so that the people know what you know what what early intervention is, and then in DC how it works. Because you guys have uh every jurisdiction is a little unique. I'm in Virginia. I'm learning how it works in Virginia, but it's how how it works um can really kind of impact how the kids do um in their first 5 years. So it's like the early intervention is really important. So I figured I'd ask about that.
Yeah, no, thank you. Thank you for that. Yeah, as you noted, every state has a different process of early intervention. So early intervention, just kind of like backing up for our parent ambassadors for everybody, right? This is determined. There's two things here. So I know that in the behavioral health space, there's the concept of prevention and early intervention. And then there is the practice of early intervention from the early childhood intervention. In terms of early childhood intervention, which is what I think you're speaking to specifically, Brandon, that's what's available for families from birth to 3 years old, or from birth to 2 years, 10 months, because you start transitioning out in terms of eligibility. If you're just about to turn 3 years old, you're probably not going to be eligible for early intervention via special education, right? And so in special education, how the law was created, it started in the 70s. So you'll see that there is Part B, which is what we typically know in the K-12 system. But then Part C was introduced about a decade later. So the early childhood comes in at a later part of the law than the K-12 system. That's because it was sort of an afterthought, or it came out of advocacy from like Head Start. So the point is that the advocates realized that disability starts in utero, at birth, especially if you're a parent that's birthing and you have a disability or a condition that may or may not be identified when you're pregnant, which is why it starts at birth. So if your child is identified in the NICU, or if your child is identified while you're pregnant, like Down syndrome, and there's some other genetic testing that will come up in pregnancy, that should trigger that the system should refer you to your early intervention, because their chances are there'll be a need for either short-term or long-term services till the child either ages out or their needs change. And so that's for birth to 3. In DC, the entry point is like any state. I think where it becomes personal to DC, or every state gets to decide how that's paid for. DC pays people, you don't have to use your private insurance or tap into direct Medicaid dollars to take advantage of early intervention. If your child is found eligible for early intervention, you go through an assessment and there's criteria in terms of that. We have local law that decided that strengthened that decision in 2014 to say that you have to show delays at a 25% deficit in two areas, um, in two domains, and they're different domains, whether it's your, you know, social, your motor skills, your communication skills, your visual, right, your physical skills. So there are 5 domains of development. And so eligibility is determined based on where you start. If you start in the NICU, eligibility is determined there. If you start in your daycare center and you get identified, and anyone can, which is why we're asking your child find stories. A parent can help in identifying their own child. A parent is a valid source of identification. My child needs this, and they say it to somebody who can, they should be able to call in to early stages. There should be publicly announced areas where you could call in to Strong Start, which is our Part C aspect, and they will circulate that information through your pediatrician, through your child development center. So if you see a delay or you see a concern, you can directly reach out and they can evaluate. You can also get a private evaluation and then bring that to Part C to then access services, which will not come out of your personal. You have to pay for it at least till your child turns 3 years old. That's typically how we get it. And I don't want to, turn this into a, early intervention session, but that's the gist of it, right? Like there are different categories, disabilities, just like all the 14 eligible categories for all the special education. They apply in early childhood. One that may be more unique to early childhood is developmental delay. That's typically when they don't know what the condition is. Evaluations are critical, assessments are critical. And then there's transition either in, out of the program completely because you're no longer eligible, or to transition into what we know as classically special education. That's in some of it. And of course, we'll keep unpacking this. We want your child find stories. I don't know, Danny or Mill, if you could put that in the chat. Because no matter what, however you got to get services, these are very critical questions in terms of kind of what Mark hinted at, that our system, particular behavioral health system, is in trouble. And it starts at the very youngest age, right on to the end of life. So it's a system that impacts the entire lifespan. But at AJE, we're very concerned with how families start their journey, because it's going to say a whole lot about how the rest of the story goes for you and your loved one. So I hope that touched on it and didn't take us too far off path. I'll pass it back to you, Danny. We're over time.
Thank you, Chioma. Yes, I wanted to give you all a chance to do some final remarks, but as we are on time, I just want to extend a huge thanks to Jenny, Trisha, Sandra, and Mark for joining us tonight. I know we also sent a bunch of links, so I was just taking note while Chioma was speaking, and I will follow up with you all right after this call. One last thing is that we do have an evaluation survey. So if you have a moment, please go ahead and provide us feedback. And Trisha, thank you for answering that question that Renee had, and Mark as well. So yes, thank you all for tonight, and we hope that we can see you to our last health policy camp event on Thursday from 6 to 8, where we'll be talking about family action planning.
I'll
Right.
just say, Daniela, we would not have had the result with Alliance without people in the community coming out and speaking up. We would not have gotten that restoration. I'm certain of it. So thank you.
No, thank you. We were all part of it. All right. Have a good night, y'all.
Right.
Appreciate you all. Good night.